Welcome, the Maryland Council on Problem Gambling. We are so excited to give the Dr. Joseph W. Shiraki Excellence in Problem Gambling Award. This is presented annually by the Maryland Council on Problem Gambling. The Maryland Council on Problem Gambling, we call MCPG, established the Dr. Joseph W. Shiraki Award, Problem Gambling Award, in 2011 to honor an amazing and tireless leader, advocate, gambling disorders, scholar, practitioner, and champion of problem gambling wellness. I'm excited because Dr. Joseph Shiraki was my professor during my doctoral training. This year, the Dr. Joseph W. Shiraki Excellence in Problem Gambling Excellence Award for 2021 recipient, we are awarding to Ms. Tanika Rice. We are excited to award this to Tanika Rice. Let me tell you a little bit about what Tanika Rice has been doing and is doing. This is the advocacy and leadership that we felt we needed to honor Tanika Rice because she is expanding prevention, treatment, and wellness to veterans in Maryland, who are oftentimes what we now know the wounded warriors. Tanika is a licensed clinical social worker for the Baltimore VA Medical Center Outpatient Substance Use Disorders Clinic. Tanika has a BA in clinical psychology from Towson University, a master's in social work from the University of Maryland School of Social Work. She joined the VA Maryland healthcare system in August 2009. She has remained dedicated to serving veterans with substance use disorders and co-occurring mental health issues for 12 years and continuing. She specializes in treatment of gambling disorder, and she holds certifications as an internationally certified gambling counselor at the first level and the clergy layperson's problem gambling prevention, education, awareness, and spiritual outreach certification that is provided through the International Certified Gambling Counselors Board. This is a wonderful credential for many of you to consider too. Tanika has expanded direct services to the Baltimore Veterans Administration Medical Center patients to address gambling, substance, and other co-occurring disorders. We believe on the Maryland Council of Problem Gambling that she is a tireless champion supporting our veterans, but not just veterans, but the affected others and the communities that they come from, and that is part of the state of Maryland. Okay. I want to share a little bit more about Tanika Rice's recognition. She has provided leadership that has included planning and facilitating the Veteran Administration staff training to really train up and expand the workforce better among veteran practitioners so that they can understand disordered gambling and gambling wellness better. She is a tireless advocate to expand direct services and peer recovery supports. Additionally, we are thrilled because Tanika has served as an executive board member for the Maryland Council on Problem Gambling since July 2014 to December 2020. And she was one of the inaugural Joanna Franklin Roberson Friend of the Maryland Council on Problem Gambling Board, which is a new circle that we have established to honor our esteemed leader who has helped so many of us expand advocacy, awareness, and assistance to the public. So I want to read the award, Tanika. I don't know if you all are going to be able to see this because it's glass, all right? But it's a beautiful award, and it reads, the Dr. Joseph W. Shiraki Excellence in Problem Gambling Award presented to Tanika Rice, LCSWC, CCGSO, for demonstrating outstanding excellence in gambling wellness, problem gambling leadership, advocacy, education, and clinical services to veterans. The Maryland Council on Problem Gambling, June 25, 2021. I am just honored to be able to give on behalf of the Maryland Council of Problem Gambling this award, because on a personal level and professional, we met Tanika, and I met Tanika along with Joanna Franklin some years ago when we had our first Train the Trainers. This might have been approximately around 2011. And Tanika was one of our first Train the Trainers who did such an amazing presentation during that particular training institute that we held at the Children's Guild. And Joanna and I said, we have to get her involved. And ever since the time that we invited her to collaborate with us, this focus of this conference is collaboration, but to collaborate with us to expand problem gambling and outreach into the community, including spiritual outreach. But the fact is that she is doing such amazing work to the wounded warriors that oftentimes are forgotten in our world and in our community. So Tanika, on behalf of the Maryland Council on Problem Gambling and all the people who are surrounding the state of Maryland to support and advocate for gambling wellness, we honor you and we thank you.
Thank you. Thank you, Dr. Haskins, so much.
You're welcome. You're welcome.
It's just a great and unbelievable to be honored with such a prestigious award. And the only thing I would want to say to everyone is that little things matter. You know, sharing information, collaborating with colleagues, attending trainings, those. I would say that this was such a surprise to me because I never really stopped to think about what I'm doing, just doing it. And so all of those little things that you probably think go unnoticed, someone's watching you. And what matters most is that the folks in which we work with, our clients, are being serviced and they're being provided, families as well, the help that they need. So it's just great to be working with you, to have worked with you and such a dynamic team of individuals who are dedicating their lives to mental health, wellness, and I think all of us are champions for problem gambling, and we have a lot of work ahead of us. So join the efforts.
Thank you so much, Tanika, and thank you. And we appreciate you. And thank you for continuing to be a friend of the Maryland Council on Problem Gambling. Thank you.
Thank you.
And we want to ask all of you to please add the Maryland Council on Problem Gambling to your list of resources. We've been around since 1972. We're doing great grassroots work in the community. And you can find us at our website, marylandproblemgambling.org, and also visit us in the exhibitors section, and we're available to provide you the resources you need to expand wellness in the community. Thanks, everybody. Thank you, Tanika.
Okay, well, welcome everyone. So my name is Chris Welsh. I'm the medical director of the Maryland Center of Excellence in Problem Gambling. And here I'm here to moderate this session and introduce Dr. Deborah Haskins. And I don't know if you can see this, I'm going to go through, but she has like 8 different groups of letters after her name. So it's going to take a little while. But so Dr. Haskins is a retired counselor, educator, received her PhD in pastoral counseling from Loyola, then it was Loyola College, now Loyola University. She's a licensed clinical professional counselor and an approved supervisor. Debbie is an internationally certified gambling counselor too, a board approved clinical consultant, international clergy lay problem gambling and spiritual outreach, and master's addiction counselor. She's the president of the Maryland Council on Problem Gambling and is recognized leader for over 20 years in disordered gambling. Dr. Haskins has trained mental health professionals in the US and abroad to understand disordered gambling and provide culturally relevant services. Her expertise and publications include gambling disorders and cultural competency, and social justice attuned mental health wellness. She assists practitioners in faith and spiritual communities with incorporating mental health delivery beyond traditional formats. She previously served as the International Gambling Counselor Certification Board and the Maryland Board of Professional Counselors and Therapists. She received the National Council on Problem Gambling 2017 Don Hewlin Annual Award for Advocacy Leadership and the 2015 NAADAC Unsung Hero Award in Maryland. She serves on the board of Ordained Ministry, the co-chair Psychological Review, and the Association for Spiritual, Ethical, and Religious Values in Counseling. Her current efforts include developing online virtual professional development and community wellness and equipping faith/spiritual communities to support disordered gambling and homicidal loss, trauma advocacy, and trainings. So that's a lot, but I think the big thing is for us at the Maryland Center of Excellence, that's, since before the beginning, Debbie talked about, with Joanna here, and even really at the very beginning of the Maryland Center of Excellence, Debbie's just been a great partner, and we've done a lot of things together, and hope that we'll be able to continue to do that. So.
Thank you, Dr. Walsh. I really appreciate it. Very excited. So I'm really honored and excited. And I want to first give thanks to the Maryland Center of Excellence under the leadership of Mary Drexler and the Behavioral Health Administration. I want to thank Donna Gasper and all of the team members with the Maryland Center of Excellence. And also want to thank the Maryland Council on Problem Gambling, because everything that I'm going to talk about and share also includes the work that we're doing in the community. So as a scholar practitioner, leader, and gambling counselor and supervisor, I know the importance of the theme this year. So when invited to do this keynote, I decided that my call would be to focus my presentation on what I have spent my entire counseling, community wellness, and lay ministry career doing. And the title of this keynote, as you see, is Culture, the Soul, and in parentheses, Psyche, Behind the High, and Praying to Win. ? Cultural diversity in addiction, engaging cultural communities, including faith-based communities. And so I want to give you my context very quickly too, because this isn't just a professional presentation for me, but I'm situated in the faith community. I supported, along with my husband, 30 years of ministry in the United Methodist Church. But I often tell people I'm always about diversity. I was born and raised by a Southern Baptist African-American mom who we converted to Lutheran when my mom married. Then I've worked at a Baptist pastoral counseling agency. I taught at Loyola University, Maryland for 16 years, which was a Catholic university. And basically, I say all that to say that the way that I function is ecumenically. And so I'm hoping that all of us will be more inclusive too, because that's what we all are trying to do in helping people to breathe better. So really what I want to do is share with you some important awarenesses as you expand your work into the community even more. When my esteemed supervisor and dear friend, Joanna Franklin Roberson, trained me at the Psychiatric Institute of Washington in the early 90s, when I worked with persons with addictions as a pastoral counseling student and intern, I felt what was really the issue with many of our patients and clients at the time was that there was a soul behind the high. There was a soul behind the high. There was a soul crying out that was hurting. I felt my work needed to focus on this soul and helping people and folks heal by healing their soul. The soul was often crying out. And when we talk about culturally diverse communities, they're crying out even more. The objectives are these three very quickly. The first one, hopefully to understand the contributing risk factors. I'm just going to very quickly highlight ACEs, adverse childhood experiences, trauma, systemic racism, social determinants of health that influence addiction and problem gambling among cultural communities. Secondly, I want to introduce you to two new models. They're not so new, but they've been updated, newly and current components of what's called the patient-centered, culturally sensitive healthcare model that is by an esteemed research team, Dr. Carolyn Tucker and her team, Herman, Ferdinand, and Bailey, that started in 2007, 2021 updated. And then also want to introduce you to the multidimensional model of broaching behavior that is by a really esteemed research team, counselor, educator, and scholar, Dr. Norma Devines, who is at Hopkins here in Maryland. Chuxton, Keller, Agerson, Bubero, and Audubon in 2020, and the implications for addiction services. My hope is that by learning these two models very briefly, that you're going to have an opportunity to modify and expand this into gambling wellness and disorder gambling treatment and prevention. And then the last objective is to understand the asset of spiritual communities and to learn the strategies of expanded community wellness with illustrations from Maryland. So I want to start with this visual. I don't know if any of you have seen this movie. It's called Soul. Soul. This is a really great movie. It received an Oscar award, I know for sure. So have you seen the movie? I want you, if you haven't seen the movie, to think about seeing it. It's a very rich movie and would be a really good movie even to integrate into our disorder gambling treatment and addiction services and mental health. But it's received a number of awards, as I say, and the central feature of this movie, the character, his name is Joe. You see him in front of you. Joe is a middle school band teacher whose life hasn't quite gone the way he expected. His true passion is jazz, and he's really good as a jazz artist. But when he travels to another realm to help someone else find their passion, he soon discovers what it means to have soul. Well, imagine that for many of our culturally diverse individuals, families, and communities that I will refer to as POCI, persons of color and indigenous members, that include gamblers, life hasn't turned out the way that they expected. Often something has happened. For example, trauma, injustice, just life, living life. And their passion hasn't even been on the horizon. Folks are just trying to feed their families, keep one foot in front of the next. Life didn't necessarily go as they planned. They didn't plan to get divorced or separated. They didn't plan to be sexually abused and violated or raped. They didn't plan in the same in my family's experience of 2 homicidal traumas. And guess what? Along comes gambling. Gambling becomes the passion, just as Joe had passion about playing jazz as an artist, but many have never had opportunities to even learn healthy coping skills, let alone figure out what to do when disordered gambling occurs. Our goal is to help them understand and to search the soul behind the high. We provide them opportunities for passion, but for so many, they're just so beat down that they can't hang in there at all. So I want to start with this, the word psyche. Psyche means soul. Did you know that? Psyche actually means soul. What we understand is the Latin term, which said anima, which means one of the basic terms actually used in medieval psychology. Anima would have traditionally been rendered in English as soul, but in modern usage, the word psyche is used. And it's kind of interesting because when psychology was trying to establish itself as a science, it moved away from soul, language, and faith and religion because it wanted to establish itself. We know now, which is kind of interesting, that the JCAHO accreditation in 2000 mandated that every mental health practitioner and health provider needed to conduct a spiritual assessment, because there was the recognition that religion, spirituality, faith, soul, basically, is important in the lives of a lot of people. So what we understand, again, is that for many people, their faith and their spiritual identity is the first hospital that they ever see. For a lot of POCIs, the hospital that they go to first is not Johns Hopkins, University of Maryland, Bon-Secours, Howard General, Chesapeake Hospital on the Eastern Shore, no matter whether it's a community hospital or a medical hospital, research institution like University of Maryland. The first hospital that many of them will access is their faith community and their spiritual communities, or their indigenous healing, non-traditional indigenous healing. And so my esteemed professor, Dr. Joseph W. Shiraki, who Maryland Council on Problem Gambling has named this award of excellence after, he even understood the value. Dr. Shiraki actually specialized his scholarship in looking at religiosity, and he even looked at what was called scrupulosity, which is when there's an excessive component of religiosity. But that's another workshop and conversation. But basically what we understand, and in my teaching and training as a pastoral counselor, we understand that we need awareness and competencies to forge therapeutic relationships that integrate mind, body, soul, and spirit in mental health delivery and health delivery as well. So in this keynote, I'm going to highlight why we must expand our community partnerships to include faith-based and spiritual partners, as we can't do the work alone. We must respect and equip these communities, because guess what? They're first line responders. They are the first line responders that show up on the scene when a gambler is in heart and soul trouble, or a person is experiencing social injustice or depression, anxiety, stress, whatever it is. They are the first line responders. And we want to add these first line responders to our gambling wellness and problem gambling so that they can get the care support they need. So the reality is that many, guess what, are praying to win. I have gamblers that come in, and you have gamblers that are coming in for services, or you have clients who come in with addictions and they're not even talking about their gambling. But guess what? They, like one of my clients, Mary, we'll call her a different name. That's not a real name, of course, but she used to play the lottery. And guess what? She would write down the scriptures while she was in church, and she would play those numbers right after the church service. So why are they playing to win, like Mary? For a variety of reasons. Many of it are playing to win because it's an entertainment. But we also know that many are playing because they can't count on America having equal opportunities for all. That's the reality. They will take their odds. They will take their odds on prayer, if you will, versus relying on applying for jobs on an unemployment system that for some of them, they're still trying to get unemployment from. They know that they're not going to necessarily have the same equal opportunities to access the resources they need to feed themselves and their family. They're stuck in many times unlivable wages. They don't have access to healthy food because guess what? In their neighborhoods, there's food deserts. And even for the middle to upper middle class POCIs, the reality is that they will still be treated differently oftentimes than the majority members. I often tell people when I step out into the world, they do not see me as Dr. Haskins. First of all, they see that I'm 6'2.5" tall. I'm a tall woman. but they also see that I'm a tall Black woman, but they may see that I'm a Black woman first. And they will treat me oftentimes based on my visible racial reality. And so it doesn't matter that I have worked hard to get this education, or that I even have moved myself and my family up from, when I was born and lived in Cherry Hill, which is a very economically challenged area. A lot of people don't know that. And they automatically assume if you came out of Cherry Hill, that not good things come out of that. They don't often listen to what your story is and hear what your soul experience is. And so many of them are counting on the lottery. They're going to be counting on the sports betting. They attend casino gambling, electronic gaming venues. They engage in a lot of illegal gambling in the community, because their reality is they cannot rely on perhaps some of the same opportunities that the dominant members may. And so let's look next very briefly at what does the research say. The research shows, and I'm a scholar and practitioner, is that the research shows that we're still lagging behind to try to understand what are the experiences of persons of color and Indigenous members, families, and communities. While we have a lot of prevalence studies, we're doing a better job of inclusion. What we're still lagging behind is, well, what do we do after we understand prevalence? How do we provide disorder gambling treatment? How do we design more culturally appropriate and more culturally inclusive prevention campaigns? The Maryland Center of Excellence has been doing a lot of work in that regard, and we have other wonderful affiliates around the globe, around the United States and even abroad, that is doing some good work. But in terms of helping practitioners understand how to connect the dots, we still today don't have any kind of handbook or clinical guide. So research continues to lag behind. Culturally diverse, this is one study that looked at an N of 11,000, a pretty large sample size. And you can see this in front of you. They looked at it at over a 20-year period. And they found in 18 published peer-reviewed articles that what they could document was that there was an early onset with older adults when the culture promoted tolerance of gambling activities. So what that means is that, as we already know, and many of you are learning more and more, that when the community or when the family gambles, then that is normalized. Society normalizes it. So even culture normalizes it. We also know, and I write about this in two of my publications in 2014 and 2011, persons of color and Indigenous persons experience higher risk. And what we know also is that they do not access treatment. And I'm going to share with you one recent hot off the press publication by Victor Ortiz, one of our gambling advocacy leaders in the state of Massachusetts, who they're doing some great work there as well. But research continues to lag behind. Researchers have to be interested in the need. We're not going to get any further if we don't have people who are in the scholars community like myself, who figured that it is important to share this knowledge. So we've got to get better. We're still not where we should be. Many POCIs don't seek treatment, as I stated, and many community members rely on their own native and local healing and help resources. I said this in a recent workshop. When I drive through Baltimore City, my great home, people are doing their own group therapy in their communities. Let me say that again. People are doing their own group therapy in their communities. And why? They're out in their neighborhoods talking to their neighbors, to their brothers and sisters in the community, not literally their brothers, but in many cultural communities, non-blood relatives, you have the same level of affinity and respect and connection as the non-blood. But they're talking to the people they love, the people they like, the people they trust, and the people that they feel work for them. Treatment is not familiar to them, and treatment does not often reflect their cultural values enough. to date, as I said, we still don't have sufficient research and literature to connect the dots. And I'm actually going to be focusing on developing a handbook of some guidebook to help us to learn about cultural matching. And hopefully that will probably be about a 2-year project, but we need more people to do more research in this area. And so this is an interesting study too by Kuda and other research. What they found, again, is that the research on gambling disorders among minority groups is scant. The prevalence of gambling disorder is high. Racial and ethnic minority status in and of itself is not a risk factor for gambling disorder, but it may be a proxy for underlying risk factors. And so I'm going to highlight what those risk factors are next. What it means there, what I want to highlight here is that we need treatment and prevention for different cultural groups to really be more infused based on what the cultural nuances are. Okay, so let's very quickly look at what are some of these risk factors. The first one, many of you are already familiar with social determinants of health. And what is this? Social determinants are the conditions in which we are born, the conditions in which we grow, we live, we age, and it also creates and shows the complex institutional, social structures, and economic systems that shape these conditions. Let me say that again. Social determinants of health basically highlight where we are born, what we're born into, where we live, what we do in terms of work, what's available, how we age, as well as the institutional, social structures, and economic systems that shape these conditions. And what the scholarship shows is that social determinants of health can predict up to 80% of the outcomes for a person. And so there's a lot that we're not in control about. And so what do we mean by this? If there's a liquor store on every corner, no surprise, we have higher rates of substance abuse. If we have electronic gaming venues in the communities, if you go out to the suburbs, you are not going to see a liquor store on every corner. You're not going to see electronic gaming venues in plurality, just within, blocks and 1 mile of each other. If you see a high location of these venues, you can be sure that we're going to see more risk factors. So it's no surprise. We can't even locate opportunities for children and adults to have access to food security, recreation in their neighborhoods, and this includes our rural settings. No surprise that out in Western Maryland, what I learned when the Maryland Council on Problem Gambling did an outreach there a few years ago, the volunteer fire departments have big money flowing with their gambling nights. Guess what? They can roll in about $7,000 that drops in one night. And I asked, why is that? Guess what they told me? They do it because they problem solve, because they cannot count on the federal, state, and local funding sources to support them like they're supporting the cities, for example, to provide the needs in their communities. And there, we know there's still disparity even in the cities. But what they decided to do is to take the matter in their own hands. And by doing that, it has also expanded some of the risks to that community. And so what do we need to understand about social determinants of health as well as health equity? This is, as I said, I'm going to introduce you. You're going to see the link that you can access this great publication that's hot off the press by Victor Ortiz and the research team up in Massachusetts. They just published an outstanding article that is listed on the reference. These authors argue, and rightfully so, that the field of problem gambling is often disconnected, often from persons of color and indigenous members and community members who have lived experiences about what life is like for them. By not including their voices and their experiences in our public health models, we can't provide them the level of wellness, treatment, and prevention that ultimately brings about change and awareness, help, and ultimately hope, which is the theme of the community and our mission for all of us as gambling advocates. When we understand that they have these lived experiences and what that really means, and we collaborate with regular people in the community, such as Massachusetts and such as we're trying to do better and do more of in the state of Maryland. We want to, team up with them and find out, what do they understand? What's really happening in their world? This research team and advocates argue for a health equity lens as well as a social justice lens and public health model, so that responsible gambling is not sufficient in it of itself. We can't just talk about responsible gambling separate from health equity and separate from social determinants of health. We have to also add a social justice and a health equity lens to the public health models. And so people can't be responsible if the conditions they're born into, the conditions they live in, and they still struggle every day to improve their lives. They can't do it on their own. Okay, so this is a link that you'll be able to access, and I have it here, but you can Google Scholar this. It's downloadable. Our Voices Matter, using the lived experiences to promote equity and problem gambling prevention, and it's available through Springer Link. So there's a commercial, and I was trying to think of what this commercial is, but there's a commercial, and I see that there's some questions that are coming in to the chat, but we're going to have an opportunity for you to do that. But there's a commercial that says, what's your reality? My question is, what's your cultural diversity plan? What's your cultural diversity plan? And what I'm encouraging all of us to do is to make a cultural diversity strategic plan. Make a plan on how you can improve the health outcomes with the communities that you are supporting. And let me just say this. A quick example is when I was the clinical consultant and a diversity consultant for Spring Grove Psychiatric Hospital. I was there for probably 7 years. And what I did was I worked with the psychologist interns for 12 months. And I did a diversity seminar with these psychologist interns to help them learn better how to infuse cultural competency in the work that they were doing at the psychiatric hospital, but more than that, as they moved into the profession as psychologists. And what they noticed was that many of these patients that were coming from Baltimore City, they just didn't really understand their lived realities, because many of the interns were European descent or white, visible white interns. And we had some who were persons of color as well, but many of them were from the dominant majority European descent community. That's not so dominant, of course. We have more integration in many of our states, but the reality is in the profession, we still are not as culturally diverse as we probably could be. And so what I started to do in year 2 is I got permission from Spring Grove, the Department of Psychology, to take these interns on a drive around in Baltimore City, because I wanted them to see the environments that many of the patients are coming from. And guess what? These interns were struck by the realities. They said, why is there a liquor store on every corner? Why do you have rows of boarded up housing and a person is living in the midst of a boarded up house? Why do we not see healthy food options in the community? It's no surprise that many of these patients have severe health conditions and have higher rates of disease. And so that was very interesting. I want to just click this on. When you get a chance, go to the healthcare access and quality. And I'm just going to click this on really quickly. And I hope that I can get back to my presentation because, I'm not a technology person, but I want to show you this real quickly. There's the Healthcare 2020 plan, and then we also have the Healthcare 2030 plan. And so when you click this on as an agency or as a practitioner, you'll scroll down, you can see what the options are. That as an agency, as a practitioner, as a preventionist, you can take a look and decide, do you want to focus in your strategic plan on healthcare access and quality? Do you want to work on increasing your knowledge to adolescents, who we now have more people facing behavioral health conditions because of COVID, particularly in pandemic education? But I like, the different options: drug and alcohol abuse, health care, improve the proportion of people who can't get medical care when they need it. We could modify that to say, how can we improve the proportion of people who can't get mental health access when they need it? Well, the good news is that I feel good about this, that guess what? COVID 2019 has made life a little bit better in this regard. And why? And I'm going to talk about that next in a couple of minutes. But I also want to point out that there's the risk factor for many POCI of adverse childhood experiences. Now, I'm not going to go into details because that's a whole nother training that you can find. There's trainings around that's accessible. And if you need to get access to the training, you can email me at hello@drdeborahhaskins.com. I'm more than happy to share resources because this is an area that I do a lot of work in. But basically, what's important with the model that you see in front of you is that while we understood when the CDC, the Center of Disease Control, and Kaiser Permanente conducted a massive study on childhood adversity, and what they had in their sample size was over 17,000 respondents. This was largely a European descent, visible white sample who were middle to upper class in terms of economics. And guess what? The majority of them experienced childhood adversity. And what they found is that when you had a score of 4+ on the ACEs questionnaire, that predicted diseases in the future. And so what they started to do, Dr. Nadine Burke-Harris is a great pediatrician who's done some great work out in the state of California. They started in the state of California to provide wraparound services. You would do the ACE score during intake, and when you see that someone has an ACE score, you would want to follow up to see what is it that they need support in. Well, what was missing in the original model, which is amazing, is what the researchers Dr. Wendy Ellis and Dr. Dietz in 2017 at George Washington University in DC said, wait a minute, it's not just about family adversity, that there was emotional and sexual abuse, there was mental illness, there was neglect, there was maternal depression, there was interpersonal violence, there was homelessness, if there was incarceration, which oftentimes we don't even ask people about. It's no surprise that you have challenges. But what happens when there's adverse community environments? And so that's the missing part. They recreated the ACEs pair to say, wait a minute, it didn't just start with family adversity, it started with adverse community risk. When you have poverty, when you have discrimination, when you have community disruption through gentrification and development, which is displacing people from their homes and affordable homes, when you have lack of opportunity where people can't even get to jobs, they have to take 3 buses in Baltimore City to get to a good paying job. If they don't have access to transportation that links up, they don't have good housing, there's community violence, it's no surprise that you have now adverse individual adversity and family adversity. So these researchers have done an amazing job by trying to highlight that we need to do better, and we need to address from a systemic and structural policy level, how can we help people with their soul experiences when they're facing all of this? Okay. COVID-19, as one of my colleagues, Dr. Diane Reese said, and I love when she said this last year, COVID-19 pulled the curtain wide open to systemic racism and racial trauma. Basically, what happened is we could hide behind the curtain, but last year when George Floyd was murdered right before everybody else's eyes, and it's not just stopped with that, what you have is you have gamblers who are part of those victims and experiences too. They have these experiences where they are being mistreated in the world and they are breathing through racial trauma and social injustice. So if we are not providing support for racial trauma, then we are missing the boat. I have done more racial trauma education in the past year for nonprofits than I have in the last 20 years of my professional life. And I've been in the profession actually for close to 30 years. People are tired, but we have not been trained, or even many of us have personal biases that prevent us from even recognizing how to help our gambler and the person that's addicted. It's like if I go to a doctor and I was hit by a car and my shoulder is out, but my toes were also broken, then the doctor only does surgery on my shoulder, but leaves my toes broken, then I'm not going to be able to walk and I'm going to be in constant pain. Well, guess what? People are broken, and in order to heal, we have to provide the full emotional surgery, not just the part we know best how to support. Okay, and so I'm going to show you this because this is available. This is from Dr. Lillian Comas-Diaz, who is a Latinx psychologist doing wonderful work on race-based trauma. Not just that, but I've been a follower of Dr. Comas-Diaz since I started teaching in psychology in 1995. But they've done some really amazing work on racial trauma and social justice trauma. But this is a wonderful brochure that I encourage you to Google it. And they define race-based trauma. And I'm not going to go through all of this because you can Google this and you can get access to this on your own. But basically what race-based trauma is emotional or physical pain, or the threat of emotional or physical pain that stems from racism in the form of harassment, discrimination, or discriminatory harassment. What's interesting is that race-based trauma is similar to PTSD because you have intrusive thoughts, you have avoidance. When you see that the world is mistreating you, you may avoid certain experience, or you may not go into a certain workplace because you don't feel safe. I was in an interview. The person being interviewed wanted to know how safe was this environment because she probably was checking out the environment to see if it was culturally supportive. And they didn't really understand, the interviewing team didn't understand that. And I had to explain that that is one of the areas that people of color and indigenous persons are always scanning, scoping out the environment to see, is this a safe environment? And that includes people in the faith and spiritual communities, because they're not separate. Race is not separate from soul and spirit. Oftentimes it all comes together. And so this is a brochure. I recommend that you hang it in your office, even in your virtual office, have it around in your health settings so that clients can see it. They can know that this is a place that will support me. This is a place that will listen to me. And so how can we collaborate for change? This is the question. I want to introduce you now to two of the models. The first model is the patient-centered, culturally sensitive healthcare model by Drs. Tucker and the research team. They started this work, as I mentioned early on, in 2007, and it's been expanded to look at how do patients view culturally sensitive healthcare. So the research team in this model, they refer to healthcare, this should say healthcare, a typo here, that is responsive to what patients and clients consider. You know, they were looking at healthcare, but we use the word client care, right? But some of you, if you're working in a psychiatric hospital, we know the language may be a little bit different. But whether it's patient or client, what they are talking about is how does the client or the patient view culturally sensitive care? What do they want? What do they need? What do they perceive? What do they feel in the healthcare process from a patient or client's perspective? Because there's been a ton of cultural competency scholarship, and I'm one of them. But what the scholarship has focused on is, let's survey people, the researchers, let's survey the practitioners, let's build theoretical models to understand how we view the professionals, what cultural competence is. But we're not citizens in the world. I mean, we are, but we're not just people in the neighborhood. We're not necessarily the patients or the clients also who are accessing healthcare. So in this model, it's looking at the care of the patient or the client also becoming more empowered. And so this model is an empowerment-oriented model. The focus is to be inclusive of cultural competency and to convey the patient desired needs and wants. And once you get that information, to make the modifications based on what this client is asking for. Like, I remember, and I believe that counseling is good for everybody. I am a consumer of counseling myself. I believe that counseling therapy is the way, truth, and the life, along with being a person of faith and spirit. But when I go to see the therapist, I have said, when I did grief therapy, I don't want to go back in time to, my childhood. Done that, been there, don't need to do that again. What I need from you is X. That's what we're talking about here. What is it that the patient or the client needs to feel comfortable, to feel respected during the process, and to trust us more? All right, so let's take a look at the model. By doing this model, the model says by implementing this more, it helps us to eliminate health disparities, because you're getting the patient's needs more, and you're probably going to be more inclusive of all their needs, or more of their needs, or more comprehensive in how you acknowledge those needs. It also, the research team created this wonderful Tucker Culturally Sensitive Healthcare Provider Inventory. And basically what it does is allows the providers to self-assess. It actually just should say allow the patients to self-assess the provider's strengths and areas of growth. No, actually, I'm sorry. This particular measurement is for the providers to do the self-assessment. And so this gives you an opportunity to sort of develop your own strategic plan. So I got that mixed up. What they found in the research is that there are 4 important factors of patient-sensitive, culturally patient-centered, culturally sensitive healthcare. What is the interpersonal skill of the practitioner? Is the practitioner able to establish a comfortable relationship? Many people of color and indigenous persons, what they value the most is how you interact with them. They trust us more based on the relationship. And a lot of that has come from history, particularly like with African descent persons, African Americans specifically, because of the Tuskegee syphilis study that harmed African Americans, and they mistrust. Many of you have already learned about that. Native members who, lost their land. There's a lot of examples. Even in the Jewish community, because of the Holocaust, there's lots of history that helps to explain why people don't trust institutions. So that's one factor. The other one is, how conscientious are we? Are we paying attention to what they're saying we need? So for example, a lot of people of color, symptoms are overlooked or minimized because the practitioner doesn't validate their voices. And that may be part of unintentional bias that's coming through, even in the healthcare delivery. They also want to know, how sensitive are you to their needs? And is the practitioner disrespectful or disempowers them or discounts the person? Okay, so these are important factors to look at. This just tells you in summary what the model is and what the terminology is. But basically, in short, this is the model. And this has implications for mental health care. What they found is that if the healthcare environment, and I want to challenge us to look at this better, what are the environment policies and procedures that are not culturally sensitive? What kind of changes do we need to make in the environment? Is the environment inviting? When I come into my doctor's office, does it look sterile to me? Do I see faces that look like me? Do I see artwork that is culturally inclusive? When I worked at a pastoral counseling agency, they had a picture of the 12 disciples with Jesus being God was white, and the 12 disciples were white. And I said, we need to take that picture off, and we need to find a more culturally inclusive picture so that people can feel that their faith experience is invited here. And if we can't do that, then we shouldn't have that picture up. Do we have magazines and publications in the weight room that's reflective of the culture? But when we make those changes, and we also have providers that are making changes to their behaviors, but they also include the staff. What this model does is train the providers, train everybody on the staff. That includes the custodial workers and environmental safety people, the support staff, the administrative staff. Everybody gets trained in cultural competency. When that's done, then you tend to have increases in provider cultural sensitivity. When they see cultural sensitivity, they trust the provider more. Then if that means that patients tend to have greater interpersonal control. They feel like they can trust the provider more. I can exercise my control in this health environment. I might feel less physical stress. I have greater satisfaction with care. And then what does that do? We tend to see more positive outcomes on the right side. You see greater health promoting lifestyles, because guess what? They're adhering to the practitioner's plan that they collaborated with us on. And that even included in the physical sense, they have more dietary adherence, they have more medication adherence, because many people don't want to take medication. So this is a really great model, and we don't have enough time to go through all of this, but I did want to share that there's some scholarship that they expanded with Asian descent communities and Latinx communities, and they're seeing the same results: greater patient adherence because they see greater cultural sensitivity. All right, this just shows you some of the items. And so I just wanted to share a couple of these with the Tucker questionnaire. Am I helpful to my patients or clients? Am I respectful of my clients' religious beliefs? Or I would modify it as a practitioner because I work ecumenically. My clients' spiritual beliefs, because some people have experienced religious oppression where they felt that the religious institution has taken their power away, or maybe they have not even the right construction. As one of my clients say, I don't trust God because God abandoned me. I trust nature. So just very interesting. So these are some questions that I want to share with you, because I do believe that these questions are easily integrated. And these are some of the questions that Tucker mentions. Ask your clients, what does or could your doctor or your addiction counselor or your mental health practitioner do to make you feel comfortable with him or her? Or what has been done that has made you feel uncomfortable? What makes you trust me better? Or what makes you not trust the practitioner or health provider? What does or could we do to show more respect and to be sensitive to your needs? What could we do to show that we're respectful of you as a person of color, or as a person from an indigenous, including as a person in a rural community? Because sometimes we don't even respect the rural community. We don't include their voices enough. And so it could be looking at even geography in terms of that. What can your doctors or your practitioners do to become better able to help you in your racial, your language, or your cultural background? What are some of the physical characteristics of this setting that can help you feel more comfortable? For example, even the virtual setting is creating a lot of anxiety for people because they're not comfortable in a virtual setting. They don't want their camera on. If we make that a requirement, why does that have to be a requirement? If the person doesn't want us to see their home because maybe they need that protection, or maybe they don't feel good about their home. So these are just some questions. And then I'm moving to the wrap up. Last, improve the cultural broaching. Because in this climate of social injustice, as I mentioned, we are expanding telehealth like never before. And I'm really excited by this. And I'm not going to have as much time to go through the cultural broaching model, but I want to highlight it, and you can check this out when you have time, because basically what Dr. Dave Binns and other scholars at Hopkins are doing is they're asking us to be more intentional. And I don't feel like I need to spend too much time on this, because I really feel that practitioners are doing much better about being culturally intentional, but we're still having some challenges. And this is a challenge I see. I see that where you see the definition. What is cultural broaching? Cultural broaching is the deliberate and intentional effort to discuss those racial, ethnic, and cultural concerns that may impact the client's presenting concerns. And what the disconnect is that because we still struggle with racism in our country and white supremacy and social injustice, that sometimes the practitioner may not feel comfortable including that as part of their health delivery. That's the work that we have to do, because guess what? People are not going to come in and see us. So the question is, what is your cultural broaching style? Do you have an isolating style where you broach minimally or quickly or in an obligatory manner? Or are you further along where you're like me and some of my colleagues and some of you, more infusing, where you're comfortable talking out loud about your experiences with racism, microaggressions, social injustice, poverty, whatever it is? Think about this, because some of this is part of our developmental work that we have to do. And then just real quickly, this just tells you the 4 domains. Like the first one tells them, how do you negotiate the interpersonal relationship and dynamic when you meet with your client who's addicted or your gambler, I would add. That's the intra counseling. Are you able to do the intra-individual, where you permit the client to discuss the intersectionality of their lives? Because they're not just a visible racial person, they may also have a sexual orientation, they may also have a gender non-conforming, they may also be breathing through trauma and poverty or whatever it is. They may be a woman who is not included in the workplace. So intra-individual recognizes that power, oppression, and privilege is dynamic and can vary and change over time in any given time and any given moment. And you have opportunities to talk to your clients about religion, linguistic, immigration status, and the intersectionality of all of those domains. And these are the last 2, you know, REC. Do you address the cultural issues that arise when you do have a sharing? So for example, with the white men clients, I might say to them, what's it like for you to seek help from me as a Black woman? Is that something that is normal or native in your experience? What can I do to help you feel comfortable? What's that like? Because there may be even power differentials that they may not feel comfortable with. And then the last one is inter-RAC. You know, can you facilitate conversations openly about some of these varying forms of racism and discrimination? All right, so the question now is, because this is, how are they praying to win? How can we collaborate for change? And I'm going to flip through this because we have a poll that we're going to start with. And I just thought this would be interesting for you to see if you can respond yes or no. Do you engage faith and spiritual community stakeholders in your addictions and mental health services? So let's just take a look, because we've got a large sample size here. and want to thank the tech folks for their amazing work. And then we'll get ready for the questions. Okay, so I think we're close enough. It looks like, yes, that's wonderful. So it looks like people are largely. Someone raised their hand. Okay, and we have about close to 40% that's not. So again, you can include, try to get more training, and feel free to reach out to the Maryland Council on Problem Gambling, because we have the Faith Initiative. We can help you with problem gambling outreach. We have some great opportunities that we'll introduce. And I'm going to just share with you a couple of things, and then we'll have the QA. So my question to the listening audience here is, how can we expand from the 5% and not just focus on, how can we help the 95%, not just the 3 to 5% that comes in for treatment, okay? Because we still don't have enough people access. And I have 3 tips. Strategy number 1, use EMIC, which is culture-based, versus EDIC, which is universal, approaches to address cultural needs and designs in your treatment. And I have a couple of resources. I have a book chapter because I do a lot of work with African descent members. I also do a lot of faith-based work. So I wrote a publication that you can access through Baylor University, Congregational Support for Problem Gambling Ministries. And just, even though this particular publication was for a Christian-based audience, you can make the modifications yourself to include more ecumenical and spiritual, non-formal sort of experiences. Strategy 2 is expand public health to appear non-pathological. Use a health equity lens. If we only offer trainings and community outreach that says gambling disorder, no surprise that no one will come. It's like when I had a group that I was trying to market and offer in a church, incest survivors. Do you think anybody came? No, they didn't feel comfortable. So in this podcast that is on my website, feel free to access. Episode 3 is where I talk about I am here, culture is home. Because the author, Dr. Prabjit Singh, said, how can we, as a part of COVID-19 and telehealth and the pandemic, how can we enter people's home? I said, the way we enter people's home is the recognition of understanding that culture is home. Okay. And then I just want to show you this real quickly. I'm sorry. Because now I want to give you just some examples. This is a project that I did with the Baltimore Washington. You can go check this out or follow up with me because we don't have time and I don't want to cut into the QA. But basically what I did for the Baltimore Washington United Methodist Church, and I'm a United Methodist myself, my husband was a United Methodist pastor for 30 years, I developed a 12-month public health strategic plan and gave them everything they needed to implement mental health and public health at the congregational level and for the community. Gave them the social media, give them the culturally based media clips, give them fact sheets and resources. Just make it available to people. Strategy 3 in 3 points. Collaborate, really collaborate, and equip faith and spiritual partners and others. And then these are just some examples of work that the Maryland Council on Problem Gambling, I'm proud to say we're doing great work. And Reverend Richard Davis is one of our graduates of our training. And he developed, along with Dr. Paula Langford, who was one of our former Dr. Joseph Shiraki awardees. And you see her on the right, and they co-host this live streaming show called Just Enough, where they focus on mental health. And Dr. Langford did a great session on us on anxiety during the pandemic. One of the recent works that I'm doing is expanding community wellness with my work with the Baltimore Washington UMC. What I recommend is that we don't brand it gambling disorders, but talk about men's health and wellness. And while you're doing that, talk about what happens when people don't respond in a healthy way. And I told them we also needed to do one specifically on men of color. See me, I am here, men of color. And while we're at it, we're going to be talking about addiction. We're going to be talking about gambling. We're going to be talking about all the ways that people may struggle in terms of their health. And Anthony Parente, my esteemed colleague, who I'm really grateful, did the first one for us. Here's an example. Dr. Mary Robinson, while she was pastoring Essex United Methodist Church, that she noticed a lot of food insecurity, that people were gambling. And so she got a small grant in the church and put the information on the recyclable food bag. But we also have some of our recent awardees. Dr. Sean Ashworth has done a great community outreach called Food for Thought Community Outreach, where they reached and served 482 people and gave them information about gambling during their feeding program. And these are just some quick pictures. Michelle Jackson did a couple of wonderful sessions. Coffee, Tea, and Me reached almost a total of 40 people. I'm sorry, 27. And then Reverend Dr. L.A. McCrae has a Project Liberation that has been conducted, and they had speakers, and she's training up the chaplaincy as well. And they had 3 events. And so people are doing some really great work, and we're very proud and happy. And so I'm going to ask Dr. Welch to come on, because the last one I wanted to show you is that the Maryland Council on Problem Gambling has expanded our outreach into the community. We had an intern this year, and we're very thankful to Judy Sherwood, who has expanded our reach in Cecil County, Western Maryland, and Ocean Downs. Those were the 3 specific areas that we're trying to expand through our faith initiative, as well as just the overall Maryland Council on Problem Gambling grassroots advocacy. So I hope, Chris, that I stayed within my time. I might have cut in. These are just some resources that I'm recommending for people, but let's take away with the QA.
Okay, well, thanks, Debbie. That was a lot of great information. And yeah, I think we only have a few minutes, but maybe
Okay.
I think they saved the questions, so maybe you can get back to people individually.
Okay.
But I mean, I don't even know where to start since we only have a few minutes. But so someone just asked your thoughts on lower income and people with lower income paying jobs being more likely to try and gamble just to improve their income, and, you know, kind of more from trying to get ahead and financially, not for enjoyment's sake.
Absolutely. Because, you know, I've been saying this even before, you know, we have more research now that's highlighting this, but I've been saying this my whole career because I got it, that people gamble for financial strategy because they need a way up. And they can't access resources in the same equal ways. And so that's why the health equity lens is an important part of expanding the paradigms that we're using in public health. Is not sufficient to just talk about gambling disorders and to say gamble responsibly, but what are we also doing at the community level and collaborating with state and local policymakers and looking at expanding opportunities with livable wages? Are we providing, you know, are we advocating for that in these same communities that we're also doing outreach into? So what I feel like we want to do is we want to expand what we're doing in the traditional gambling advocacy role. We have to expand on that. And we've got to be at the table with some of these other policy sort of decision makers to say, how can we get jobs into the communities? How do we make sure that people have access to employment? Because it's not sufficient to just tell them not to gamble. That's an awareness, but we've got to also look at how can we help them problem solve. So I know that there's not enough time to really go into depth with that answer, but that might be a future workshop that we can even offer to really just focus on people who are living in material poverty, and to have maybe even a panel of people that can talk about what are the resources in the state to help people who are experiencing economic challenges, and how do they get access to these resources so that they don't gamble as their primary resource.
Great, thanks.
Yeah,
We
because
just got the okay, we can go on for 5 extra minutes. So.
Great, thank you.
So there are several people asking just for resources. How can I get posters about racial trauma? Do you have posters with cultural competency information available for participants to put up, like in offices and things like that?
Okay, yeah, so what I recommend, I will send Donna Gasper this brochure that can be shared somehow through the Maryland Center of Excellence, the brochure from Dr. Lillian Comas-Diaz on racial trauma. But as a big resource, I recommend that you go to the Centers of Disease Control. They have wonderful, wonderful posters and materials that are downloadable that you can use. Also, if you go to SAMHSA, SAMHSA has done some incredible work with cultural competency, and you can also see on the samhsa.gov website also posters and downloadable resources that you can use. Feel free to go to the Baltimore Washington for those of you who want to do more work in the faith and spiritual communities. You can access the Baltimore Washington United Methodist Church website is bwcumc.org. And if you go to our website, you can see the 12-month public health strategy that we're implementing, and feel free to replicate it. You know, this strategy is available for everybody in the community. And so while, you know, we created it with low resource ideas, and a low resource public health idea for me is you can do postings on social media. For example, my church, what I got my church to do is to hire a licensed graduate professional counselor to do our monthly social media postings. And I applied for a small grant through my United Methodist Conference to be able to pay this graduate counselor who does our 12-month social media posting. And she does 2 posts a week. And she uploads any of the resources and materials as well. And so that's a low resource. Even if you can't hire someone, but you can get a volunteer, or you can get an intern if you're at an agency, and task your intern at your agency to be the social media person. That's a low resource initiative. A high resource initiative is if you need funds to have a speaker come in. And because most people who are in the nonprofit world, and that includes faith and spiritual communities who don't have budgets like we may have, and even the Maryland Council on Problem Gambling, we don't have a large budget, but guess what? We get it done. And because we do a lot of low resource things at the grass level, but we also have expanded. So the key is to just get access to these resources, and then figure out in your strategic plan how you can then do it where it's consistent and it's year round. That's what I really want to encourage you to do, year round, not one time only, like a workshop like Dr. Langford did was a one time only. What can we do to raise up the public awareness 24/7 so that every time a person is, you know, opens up their computer, they can see something happening? Another example is Facebook Live. I know I'm going beyond the question, Dr. Welsh, but I did want to say that Facebook Live offers practitioners a great opportunity. For some of you, you're going to get more people on Facebook Live than you will in a formal workshop. So I did a workshop, I did an informal talk with a financial advisor, and it's over 500 views already. And so, you know, that's another resource that you can do. And that way it's just circulating 24/7.
Okay. Just some of these I think would just take too long to go into. So maybe these can be more like in the discussion. Somebody wants to know what's the name of your podcast?
Okay, the podcast is called the podcast is named Culture is Home. It's not my podcast. It's a podcast done by an amazing medical doctor named Dr. Prabhat Singh. And if you go to my website for the Mosaic Consulting and Counseling Services, my website is www.dr, my name, Deborah, and Haskins.com. And if you go to the events page, you will see the podcast listed there. You'll also see the Baltimore Washington public health strategy and the one we did for the youth in the faith community as well. And you can click on the podcast that's available. I also have a diversity bookshelf that you'll see on the website as well, highlighting a lot of some of the work that you see here.
Great. Okay. Well, I think it's now lunchtime.
Thank you for
so
giving me the additional time. I did my best. A lot of information, turn me
You're welcome.
on to talk about culture, and I can go all day long. Thank you, everybody. And thanks to Maryland Council on Problem Gambling. Thank you, Dr. Welsh and Center of Excellence and BHA. And thank all of you.
Thank you, Debbie.
You're welcome.
So just want to encourage everyone, we also have the discussion board and then networking page. So you can continue some of this. We can continue the conversation there. And we also have exhibits and poster hall that we'd like everyone to visit while you're eating lunch. All right. We'll see everybody back at 12:45.